Hello students, I'm the OGGuru Dr. Punit Bhojani here with a single point agenda to make OBGY your most favorite subject, most scoring subject. Very important video as per the new pattern, video based question to how to solve the video based question for the upcoming FMG examination. And I am going to remove your fear because video based question, my dear student, is nothing but an extension of image based question. We are going to show you how a video and image, if you know the images also very well, then the video based question is going to be very easy and cakewalk for all of you. So don't worry and please remove your fear of video based MCQs. Feel free to get in touch with me on phone and WhatsApp on this number, and very happy to announce 5 months FMG course, the FMG Combo, visual everything, theory lecture, rapid revision MCQs, beautiful notes. My personalized timetable guidance is available only in 1200 rupees with this freedom sale for the next 24 to 48 hours. So please enroll soon. Download the OGGuru app, and my guarantee, OBGY will become your most favorite subject, most scoring subject in the upcoming FMG examination. Because as you know, 30 to 35 MCQs come every year from OBGY. Even in such a tough June exam, almost all the questions were from my lectures. Students have told me that. Okay, sir, so many students get stuck up at the score of 135, 141, 140, and then they take my OBGY and then they cross the 150 barrier. Because minimum, if with your current knowledge you are stuck up at 10, 11, 12 MCQs correct in OBGY, after my lecture, within few days your OBGY score is going to jump up to 28, 29, 30. 15 to 20 marks more will make the difference and will help you cross the 150 barrier. So more about this later on. Let us begin. So first we'll see the video, then the question, then I'll tell you how to interpret and what is to be done. Okay, so first let us see the video. So here we can see this, my dear student, is what? We are seeing the tube, uterus, ovary. Okay, you can see this. Okay, so I'll again play the video for you and you can start observing what it is. So you can see this is the ovary. Similarly, this is the ovary. This is the uterosacral ligament. So here is the uterus. This is the pelvis and the pouch of Douglas. So this is what view? Yes, this is a laparoscopy view from above. What is laparoscopy? Sir, we put in a telescope from above through the anterior abdominal wall and I can see the uterus, tube, ovary. More about that, how to identify laparoscopy, all that we are going to discuss. Okay, clear? So now first let us see the video and then you will realize what is being done. Okay, you can see this. Yes. Okay, so this is the uterus. Is it clear? This is one ovary. This blue liquid is what? Because two surgeries can be done together. So ये blue है वो क्या है? Blue है पानी. Yes, blue is the methylene blue dye. Why is it done? Please comment in the chat box. And then what is being done is, yes, we are lifting up the tube and yes, such a big bulky ovary. You can see ovaries increase in size and volume, and उसमें हम क्या कर रहे हैं? Yes, we are drilling holes in the ovary, isn't it? So even if you know this much, okay, sir, this is a big bulky ovary and we are drilling holes into the ovary. This is laparoscopic ovarian drilling. Why laparoscopy? Because we can see the uterus, tube, ovary. Don't confuse it with hysteroscopy. Hysteroscopy is only for cavity. It's the inside the classroom view. Hysteroscopy is only for cavity. When I put in the telescope and see the uterus tube, I'll draw and show it to you, and more videos are there. So this is laparoscopic ovarian drilling done for which condition? Yes, sir. PCOS was the old name, polycystic ovarian syndrome. Now all of us know the new name is PMOS, polyendocrine metabolic ovarian syndrome, because metabolic condition and there is insulin resistance associated. But that's not the question. So either the question could be identify. So अगर identify है तो laparoscopic ovarian drilling. But what is the question? The question is, what is the indication for this surgery? Before I go to the answer and give you the explanation, you can see the same image. So what I'm trying to do is, I am trying to show you the video and the same image. Isn't it the same thing? So this is the uterus, this is the pelvis and the pouch of Douglas, and so this is the big bulky ovary, and here we are drilling holes into the ovary. Clap. So this is laparoscopic ovarian drilling. Another name is LEOS, laparoscopic electrocoagulation of the ovarian surface. Now why I call this as laparoscopy? Yes, because sir, we can see the uterus. Moment you see the uterus, tube, ovary, it is laparoscopy. Okay, and in the previous video, blue, because pill test, okay, the dye tube patency test was also done. So two surgeries can be combined together. So my dear student, whenever, please keep this in mind. Okay, sir, what is laparoscopy? Sir, we put in the telescope through the anterior abdominal wall, and moment we see the uterus, fallopian tube, okay, ovary, that and the pouch of Douglas, that automatically becomes a laparoscopy view. Is this understood to all of you and not hysteroscopy? And now what is the question? What is the indication for this surgery? Indication for laparoscopic ovarian drilling. Now this concept you should know. My dear student, please understand this. It is almost not done nowadays, or this surgery is hardly ever done. Please understand this. Do I do it for acne and hirsutism in PCOS? Never. You'll have to go to jail. If you do it for acne and hirsutism patient, you'll have to go to jail. Jail matlab it's a big crime. Is it clear? Do I do it as a first line treatment? Again, you'll have to go to jail. Why? Because please understand this, that always for PCOS, we try medical management first, diet, lifestyle modification, weight loss, and when the patient is infertile, what do we give first for infertility? Yes, sir. For infertile patient in PCOS or PMOS, we first always go for ovulation induction medicines. Okay, please understand this, that we should know this concept, that why is the patient of PCOS infertile? Sir, because of an ovulation. So we go for ovulation induction. Letrozole is tried first. That's the first drug of choice. If not, we can try clomiphene, and if not, we move on to the injectables, HMG or recombinant FSH. Please comment in the chat box, what is HMG? Human menopausal. How do we get it? What is the source of HMG? Please comment in the chat box. I'll tell you the answer there. So recombinant FSH or HMG, both have similar action. And first we always try this. And as a last resort, when the patient is not responding to these medicines, is when I do this drilling. So it is done only for infertile patients. Please remember, I never do it in a young unmarried girl or just married with PCOS. We never do it. When do we do it? Sir, first the patient has taken letrozole, clomiphene, she's not ovulating, then you move on to this injectables, HMG or recombinant FSH, still the patient is not ovulating. That means the ovary is resistant. That is the time infertile patients who are resistant to oral and injectable ovulation induction, that is the only indication for laparoscopic ovarian drilling. It is done as a last resort. We don't do it nowadays. We don't prefer doing the surgery, but it is likely. So this is a virgin IBQ. Never ever it has been, as will come in the future, virgin IBQ also, virgin VBQ also. Okay. So once you know the video, now you know the image, okay, uterus, ovary में drilling, laparoscopic ovarian drilling, done for PCOS or PMOS. Same thing in the video. I'm very sure you could easily identify, okay sir, when we are seeing the video very clearly, you can see this over here, okay sir, we are lifting up the ovary and see the same picture, sir, we are drilling holes in the ovary. Is this understood to all of you? Yes. So this is laparoscopic ovarian drilling done for infertile patient as a last resort. Moving on to the second video. Chalo, now let us see. Some needle is coming out. अरे कुछ तो अंदर लिया क्या? एकदम छोटा सा. Something this is taken inside. What is taken inside? And then what does this look like? What does this look like, all of you? Okay, yes, so this is the human egg. Isn't it looking like the egg? And this is the holding tool. Why am I calling this as an egg? It's because here I can see the polar body, and this is the human egg. And what is being done? आगे इसके आगे क्या कर रहे हैं? Yes, the video will go ahead and you will see that needle which we had taken, and this thing is the sperm, single sperm, and it is being injected. So one egg is taken, one sperm is taken, and it is done. This is ICSI. intracytoplasmic sperm injection. I repeat, ICSI, intracytoplasmic sperm injection. When do we do this? Please understand this. What is the normal sperm count? Please comment in the chat box that at least the sperm count. Okay, so basically very simple video. Sir, egg, this is the polar body, so this is the egg or the oocyte, and inside it this is called a holding tool. Okay, this is just a holding tool, forget about that. ये नहीं पूछेंगे कि ये क्या है, holding tool. And you saw कि sir, one sperm was taken and with the help of a needle one sperm is injected into the egg. This is ICSI. Now before we go to the MCQ, see the same picture, isn't it? Cut, copy, paste, same picture. Egg, holding tool over here, see egg, needle injection, sperm, and the egg, intracytoplasmic sperm injection. So video based, don't panic. Yes, thoda sa time waste hoga because you might have to see the video 1 or 2 times. So just be quick, but there will be some time wastage in seeing the video. But by and large, my dear student, once you will surely be able to identify the video if you know the theoretical concepts, and if your IBQs are strong, you will be able to get it. Now is the tough. What is the indication for this procedure? So this procedure is ICSI. Now please understand this, that the normal sperm count is there. If the sperm count is normal, very good, the couple can naturally conceive. If the sperm count is slightly lower, okay, like 16 million per ml or more is normal. If the count is slightly lower, 10-15 million, we can do IUI. But when the sperm count is lower than that also, 5 million, we can still do IVF. What is the difference between IVF and ICSI? And in IVF, sir, in IVF, one egg is taken and on top of it, roughly 50,000 sperms are put. Okay, that is IVF. Then anyone will enter. ICSI is what? When is it done? Sir, when the sperm count is very, very low. Like 5 sperm, 50 sperm, 100 sperm. पूरे body में खाली 50 sperms है. 5 sperms hai. So then we can take egg from the wife, and in one egg we can put 1 sperm. That is ICSI. Is it clear to all of you? So please understand this. This again just by the way. Okay, sir, suppose we have a sperm count in the range of 10 million per ml. Okay, 10 million agar hai, we can try IUI. Now suppose if I don't have 10 million sperms, I don't have means I have, patient does not have. Okay, if the patient does not have 10 million sperm, but the patient has some still good million, around say 5 million, 4 million, 4 to 5 million agar range mein hai, 3 million ka range mein hai, we can do something called as still IVF. But when the sperm count is very, very, very low ka matlab 0.5 million, half a million, usse bhi kam, because at least for IVF it is 50,000 sperms per egg. So if there are 3-4, at least 1 lakh, 2 lakh sperms are required for IVF. Okay, but when the sperm count is very, very low, like 10, 100, 1000 sperms, okay, 100,000 sperms, then we can do ICSI. So virgin MCQ future mein aayega. Next year you will remember me after 2 years, how if they give you an MCQ, how even a single sperm can cure or treat male infertility. Which is the procedure? Anybody? Thoko tali. Okay, sir, how even a single sperm can be used in treatment of male infertility? The answer is ICSI. And we know the answer over here. It is not for advanced maternal age. When the mother's age is rising, the poor egg quality is getting less. Then they may require either IVF, or we might have to even donor eggs. And the mother egg is completely gone, donor eggs. Okay, not necessary advanced paternal age, because father would be 40, 50, but the sperm count would be 50 million. So not necessary age related. Yes, severe oligoasthenospermia. Oligo is the count, astheno is the motility. When the sperms are not motile, because directly I am picking up the sperm and putting it inside the oocyte. So when the sperm count is very, very low, 5, 10, 50, 100 sperms अगर हमारे पास होता है, तो उसमें से we can take 1 egg, 1 sperm and directly put it ICSI. And after ICSI, what is done? Anybody? ICSI is the combination of egg and the sperm. This egg and the sperm is the embryo, and that is kept in the incubator, and then we do a procedure called as embryo transfer. Okay, where we put the embryos 2 or 3 inside the. So remember, this question could be asked to you. Okay, after this ICSI procedure, what is done? ET, embryo transfer, because ICSI will create the embryo and ET is embryo transfer. Is it clear to all of you? So the embryos are transferred. Why embryo transfer? Because obviously the pregnancy has to grow inside the uterus, right? So embryo transfer into the uterus. Is this understood? So multiple questions could be asked to you. Okay, what is done after this procedure, all that. But image, if you know, you can easily answer. Now see what is being done in this kind of a model. Okay, so that is me demonstrating. Okay, now here you can see first. Okay, first what is coming out? Yes, isn't it baby head coming out? Yes. So this is a head delivery. Utna concept clear hona chahiye. Clear? It's a head delivery. Okay. Head is clearly being seen over here. And when the head hai, face kahan pe dikh raha tha? Face was looking up towards the ceiling. And then the baby's head falls down. Baby is still looking up at the sky. Baby is looking at the ceiling. Okay. So it was a vertex delivery. One more time we'll show you. But now first look at the MCQ. Okay. Identify the delivery being done. Is it occipito anterior? Is it mento anterior face, mento posterior face, or a face to pubis delivery? Clean bold. Students do not know this. Many students don't know this concept. Now, please understand this. One more time, I'll show you and it will become crystal clear to all of you. Okay, first, it is very clear. Okay, sir, it is a head delivery taking place. Clearly, you can say, I'll pause the video. Clearly, this is the fetal head. Isn't it, my dear student? This is the fetal head which is coming out. Isn't it? Yes. And then when the head is coming out, look at where is the face facing. Yes, face is facing towards the pubic symphysis or the ceiling of the labor ward. Okay, occiput. Why? Because the occiput is down. Occiput is posterior. Yes. So when the occiput is posterior and when the vaginal delivery takes place, this is the face to pubis delivery. Yes. So the baby occiput is looking down. Baby occiput is at 6 o'clock. I'll show you. Don't worry. So first of all, is it a face? No, it is not a face. Why? Because in face, I will feel the baby's face. When you do PV, malar mentum, when you put your finger inside, baby start sucking your finger. ऐसा क्वेश्चन आ सकता है. When you are doing a PV, somebody is sucking your finger. Somebody मतलब the baby. What is it? So face. So in the face you feel the what? Malar. This is called malar, mentum, nose, mouth. My finger go in the baby's mouth. Baby can start sucking my finger. So this, my dear student, is your face. Can you see this? Okay, sir, I can feel the baby ka malar, mentum, nose, mouth, all that. And in the face, so both these are face presentation. If the mentum is towards, this is the pubic symphysis, which is anterior. This all of you can see the sacrum. So that is posterior. समझ में आ गया? So when the mentum is towards the pubic symphysis, this is called as mento anterior. Here clearly you can see, okay, sir, mentum is towards the sacrum. So this is mento posterior face. Both are face only. So एक हो गया mento anterior, mento posterior. Please comment in the chat box. Out of these, which can deliver vaginally, which will require C-section? Both require C-section. Both can deliver vaginally, which is very important. I'll answer you in the chat box. Okay, mento anterior, mento posterior. How will the delivery take place? Which presentation is a malpresentation? Which malpresentation? Vaginal delivery possible? For which one I have to do LSCS? So ये हो गया आपका face. Extra information है ये. Okay. So this is clearly not a face because, sir, I saw the baby head coming out. So it is a vertex. At least from the picture we know, okay, sir, it is a vertex delivery or the head delivery taking place. But sir, occiput, instead of being anterior, sir, occiput was posterior. So this is because occiput was at 6 o'clock. OP, vertex OP. And this type of delivery, my dear student, is called as what? Face to pubis delivery. It is not face delivery, it is face to pubis. So please understand this. Okay, sir, normally hota hai occipito anterior. Again, to show you the picture, this side picture. Okay, see this. Okay, sir, this is the pubic symphysis. Here is this. Occiput is over here. Occiput is over here. So this is occipito anterior. And when the baby's face is in the sacrum hollow and baby comes out like this. Isn't it? Have you seen a delivery taking place? Yes. But now look over here. When I do a PV, yes, this is a vertex only. Isn't it? This is a head delivery or a vertex delivery which is there, and this is the pubic symphysis. So where is the occiput? Yes sir, occiput is posterior, and when this baby will be coming out, baby will be looking where? Yes sir, baby pubic symphysis को देखते देखते बाहर आता है. That's why it is called as face to pubis delivery. I'll draw for you one more time. Okay sir, suppose this is the pubic symphysis like this. ये हमारा बेबी का nose, stylish nose, okay, mouth, okay, and ये हमारा eyes, okay, बेबी का, and this is the occiput, isn't it? So my dear student, when I do a PV, it is vertex or the head. Simple. What is face to pubis delivery? Sir, it is a vaginal delivery which takes place when the occiput is at 6 o'clock. Is it clear? When the occiput is posterior, when the occiput is posterior, OP, matlab occiput at 6 o'clock. Okay, when the occiput is at 12 o'clock, I call it as occipito anterior here. Okay, so occiput is at 12 o'clock, to ho gaya occipito anterior. When the occiput is at 6 o'clock and when the vaginal delivery take place, it is called as face to pubis. Why? Because sir, face faces the pubic symphysis. So you can see over here, when this baby is going to come out, baby कहाँ कैसे बाहर आएगा? Sir, baby pubic symphysis को देखते देखते बाहर आता है. This is face to pubis. ठोको ताली, clap. Okay, just remember vertex, it's a head delivery, vertex OP. Occiput at 6 o'clock. Occiput at 6 o'clock, vaginal delivery, that is called as face to pubis delivery. And this is completely different from face presentation and face delivery. Many students do not know this difference even after the internship is over and the exam is over. I hope you will get it correct. Okay, so the answer to this MCQ, this is face to pubis delivery which takes place in occipito posterior. Identify the delivery. Is it clear to all of you? Chalo, आगे बढ़ेंगे. All of you can see this. This is a speculum being put. We are holding some instrument and we are holding some threads. Common sense, simplest thing. Thread को pull कर रहे हैं and कुछ बाहर आ रहा है. What is coming out? Coming out, coming out. Yes, 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 yes. So this is the IUCD removal procedure, and you can see what is coming out. Yes. Is it a copper T? No. Can you see this serrated fins like thing? Serrated fins. So what is clearly dikhega? Yes. Now it is much more clear, isn't it? So this is a copper wire. This is a copper wire, but this is not a T-shaped device. This is not a copper T. This is what? Yes, sir. This you can see. This you can see. This is a multi-load device which has come out. Isn't it very clear towards the ending? Last time again I will show you, okay, that we are pulling it out, and clearly you can see that it is looking, or it is exactly like a multi-load. So what is being removed? It is not a myrina. Myrina is completely white. LNG, intrauterine device. Okay, this is not a copper T. This is not a implant only put in the hand. This is a multi-load device. Can you tell me what multi-load? Yes, sir. Multi-load is again of two types. Both look the same. So you cannot say. So multi-load could be 250 or multi-load 375. Please comment in the chat box how many years can I use. Please comment how many years can we insert this 380A. 380A is for how many years? 250 multi-load and 375. What is the duration of action? How many years can it act? Okay, so again to show you the picture, isn't it? See, flexible arms with serrated fins like this. Same picture was there. So multi-load, and please remember both multi-load same दिखेगा. So don't say कि sir ये multi-load 250 है कि 375 है. You cannot see. That will depend on the surface area of this copper. You know that 250 होगा या 375, that number is the surface area of the copper in millimeter square. Okay, so when you see this serrated fins, it is a multi-load device. So again, image, you know, any MCQ you can answer. They can ask you what is it. So after this video, anything could be asked to you. What is the contraindication for this procedure? What of IUCD, which condition IUCD cannot be used? Some options could be given to you. What is the side effect? What is if the... So multiple things can be asked to you. Anything related to copper T, IUCD can be asked to you after this video. So the question will depend on what the examiner wants. identification should never be a problem. If your theory is strong, you can answer. Now chalo, tell me this before only. What is this? Yes, hysteroscopy ke laparoscopy. Again same thing, sir. This is the uterus, this is one ovary, this is another ovary, this is pelvis, pouch of Douglas, and some blue dye. Blue hai pani. What is this blue color dye? Yes sir, it is a methylene blue dye. And why is this test done? And it is coming out from the femoral end. So what does it indicate? And the blue color dye, you can clearly see blue dye is coming out from the femoral end. And okay, so what is this? Now the mistake student make is, okay, so what is the name of this procedure? Now the mistake student make is directly when they see the MCQ, methylene blue dye, and they will mark this as the answer. Yes or no, clean bold. Because moment 90% student, hysteroscopy with methylene blue, clean bold. My dear student, this is not a hysteroscopy view. Hysteroscopy ke saath, first of all, we never insert a methylene blue dye. Identify the procedure. So this procedure is done with methylene blue dye. It is laparoscopy chromopertubation done with methylene blue. And what it is it HSG? No, HSG is an X-ray. Sonosalpingography is a USG. So sir, this is a laparoscopy chromopertubation done with methylene blue dye. And what is it? Yes sir, it is the gold standard or the best investigation for tubal patency. If I want to confirm, okay, tubal patency test, best investigation, laparoscopy chromopertubation done with a methylene blue dye. Basically what is done over here is, my dear student, that sir, the assistant will put, you are putting in a telescope from above, okay, we are putting a telescope from above, okay, we are putting a telescope from above. So I can see the uterus, tube, ovary, all that I can see, what view had drawn and shown you, okay. And now the assistant will put a methylene blue dye through where? Through the cervix. So from the cervix, we put a blue color dye, and if the tubes are patent, okay, if the tubes are patent, all of you know, okay, if the patient's tubes are patent, what will happen? Yes sir, the blue color dye will enter the uterus, the tube, and from the femoral end, the dye will come out, which is called as the spill of the dye. And we are checking that spill of the dye through a laparoscope. So it is called as laparoscopy. Chromo matlab color, pertubation means to put in the fallopian tube. Yes, methylene blue is the dye used, but it is not hysteroscopy with methylene blue. It is laparoscopy with methylene blue or laparoscopy chromopertubation, and we are checking the spill of the dye. Clear to all of you? And see the same picture, isn't it, my dear student? कि again ये भी virgin IBQ है, never ever asked. I'm expecting it to come in this year's exam. All of you can see, sir, this is the uterus, this is the ovary, this we are holding the fallopian tube. Same both pictures, okay. Again uterus, pelvis, C tube, and blue, and you can see this blue color dye. Everybody starts jumping in the OT, okay. Methylene blue dye, this is the spill of the dye, okay. Clear? So laparoscopy chromopertubation. So picture and video same but different. देखो कितना similarity है. They will give you a classical image or a classical video. Don't worry, I am here to remove your fear of image and video based question, okay. Now again we are seeing some delivery taking place. Obviously इतना भी देख के आपको पता चल गया कि it is a breech delivery. Isn't it a breech delivery? Yes sir. Why? Because the head is still inside. Baby buttocks, we are holding the baby by the lower limb, arms are there, head is still inside. So we are doing the delivery of the after coming head. It is called as after coming head of breech is understood. Okay, so after coming head of breech ka delivery ho raha hai. And what was done? Yes sir, we hold the baby and now the head is popping out, isn't it? I don't think second time bhi dekhne ka zarurat hai if you know the basics, but just very quickly, okay sir, we are holding the baby by the lower limbs, okay. Yes. Okay, we are holding the baby by the lower limbs and rotating onto the maternal abdomen. What is this maneuver? Same picture. Okay, okay, sir. First, the baby is hanging down, down, down. You hold the baby by the lower limb and rotate it up, 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 up towards the maternal abdomen. So the head will pop out from below. This is the Burns-Marshall maneuver. Thoko tali. Simple. And that's the same question. Mac-Roberts maneuver is done for shoulder dystocia. Is it clear to all of you? Ridgen maneuver. Please tell me the purpose of the Ridgen maneuver. Ridgen maneuver, why we do, where we do. This is the answer, Burns-Marshall maneuver. And one more. Morrissey smelly wheat is also for after coming head. Why is it not Morrissey smelly? Sir, in Morrissey smelly, कैसे है? MS. Isn't it? Clap if you feel happy. In MS, you do MS. अरे सर ये क्या बोल रहा है कि सर इन MS you do, when you do MS you do MS. Yes, MS you do MS. MS you do MS मतलब कि सर Morrissey smelly you do malar flexion plus shoulder traction. Thoko tali. Malar flexion, shoulder traction means, so this left hand will go inside the vagina. I will do flexion to the baby's malar flexion. Right hand I will do shoulder traction. So combination of malar flexion plus shoulder traction is called as Morrissey smelly wheat maneuver. It is also for after coming head. Burns-Marshall is thoda sa easy. We hold the by the lower limb and rotate it up, up, up towards the maternal abdomen. Burns-Marshall maneuver. Is this understood to all of you? Okay, now let us begin and see the video. Again, what is this? Very, very simple. Yes or no? Yes. So I am pulling out a piston like this. Pichkari jaisa hai ye pichkari, and first vacuum was created. So this is what? Yes. You can see clearly that I created a vacuum for this button press kiya, and then I am putting a instrument on top of it. What is it called as? Cannula, and then we are sucking out. What is this procedure? Yes sir, this is MVA, manual vacuum aspiration. We can do it up to 4. It is always for the first trimester MTP. You can use this only up to 12 weeks. The advantage is no electricity, and this is the MVA. And what is this? Yes sir, this is the Carmen cannula, and therefore same thing, my dear student, isn't it? Anybody? So as I said again, you know the MVA syringe and the Carmen cannula. This is exactly what was there in the video. Now what is the question? What is the capacity and vacuum created by this device? This device matlab MVA. Yes. So see, that knowledge you should have, because any video ke baad they can ask you anything. Yes. So first of all, understand this is for MTP. We can use it, or if it is an inevitable abortion, incomplete abortion, also I can use it up to 12 weeks of gestation. It is used generally for MTP in the first trimester. And remember, the capacity of this is 60 ml. So it is not 100 ml, it is not 50 ml. And what is the vacuum created? Yes, around 600. Vacuum created 600 millimeters of mercury, and therefore that 800, no, that is too high. Okay, so Carmen cannula and MVA syringe, 60 ml is the capacity and roughly 600 millimeters mercury. Advantage, that is less trauma. Plastic cannula hai, no less chances of injury, and electricity not required. Otherwise I have to do a suction evacuation. जो suction evacuation करते हैं, that requires your electricity. Okay, suction evacuation requires electricity. This is not suction evacuation. You don't use the word, you use MVA, manual vacuum aspiration. Okay, is it clear to all of you? In suction, you use a metallic suction. This is the MVA syringe and MVA cannula. Okay, is it clear to all of you? Now again, let us see what is being done. So they will give you a history. What history they will give? First you see, so some nick is made at the vaginal opening. Simple, like all of you can see, okay sir, a nick is made at the vaginal opening. We are increasing it, and now the blood has already started to come out. You can see this, see, the blood has already started to come out, and when we will thoda sa widen the opening, and you can see when we just put in a artery forceps, and then pura sa reveal suspense pura clear ho jayega. What is, yes, absolutely, you must have got it correct. All altered, so much, all this brown, reddish brownish color. Okay, what will be the history? They will tell you, okay sir, this is a 15-year-old girl who has come to you with primary amenorrhea, cyclical abdominal pain, very famous cyclical abdominal pain. So what is it, and why is there primary amenorrhea and tense bulging hymen? Yes, cyclical abdominal pain, primary amenorrhea, urinary retention. So this is your this amenorrhea is called as crypto. Crypto matlab hidden. Okay, cryptomenorrhea, and this is your imperforate hymen. Yes or no? Simple. You could identify the video. Okay sir, nick taken at the vaginal opening and altered blood coming out. Okay, same picture, isn't it? Same picture, tense bulging hymen, and you are supposed to make a cruciate incision like we did, one line, or you can make even a cross cruciate incision, so that when you take the cruciate incision, all the blood will come out. Okay, these patients have presented with primary amenorrhea. Now look at the question, what the mistake student make? Directly ये video देखा, imperforate hymen, yes or no? Wrong, because lead the question. The question is not identify the condition. The question is, what is a long-term complication of this condition? Yes, this condition is imperforate hymen. Okay, imperforate hymen is the name of the condition. This image has been asked previously. This image has been asked, okay sir, the patient is presenting with primary amenorrhea called as cryptomenorrhea and tense bulging bluish hymen. Okay, so this is the imperforate hymen. And what the question is not there. The question is, okay, what is the long-term complication of this condition? Anybody, what can happen? Yes sir, all of you we know, okay sir, what is happening is, okay sir, because this is a imperforate hymen, tense bulging bluish hymen, what will happen? So the menses will start, but the blood is not able to come out. The blood gets collected in the vagina, hematocolpos, which came out, and then the blood further gets collected inside the uterus. We call it as hematometra. And what can happen with the blood? Yes sir, the blood can go retrograde. Long-term complication, blood can go retrograde, and these patients, the blood can get deposited. Retrograde menstruation theory is whose name? Please name the theory. Retrograde menstruation theory, kya naam hai? Okay, and therefore these patients have got, please comment in the chat box what is the name of the theory. These patients have got increased risk of endometriosis in the long term after 5-10 years if you left it uncorrected. Okay, so long term complication of this condition, it is not a dermoid cyst, not ectopic, it is endometriosis, because retrograde. Okay, retrograde the blood which is getting collected inside the uterus. Pele blood will get collected in the vagina. We call it as hematocolpos, and that can give rise to urinary retention episodes. Okay, and hematometra and backflow ke saath the blood can enter the pelvis. Hematometra, that is the endometriosis. Okay, so please be careful. Videos will always be easy, लेकिन आपको उसके बाद का जो क्वेश्चन है वो ध्यान से पढ़ना है, so that you don't make a mistake. And my dear students, look at this completely colored notes. My guarantee, you can revise the whole notes in 2 hours. There's a notes read along video. So many students have told me कि sir paper 1 was not good. In the break we came, we read your notes, and अंदर जाके we cracked the exam and came back. And all this you can see. Okay, whenever I felt stress and lost, sir, thank you. Your videos give me confidence. You made me below every mark I scored. The result is my victory. You can see this, sir. Thank you very much. I passed the examination, and your advice helped me to crack the exam. All MCQs, including your version MCQs. Sir, OBGY ने बचा लिया. Paper was tough, but OBGY cakewalk, and I could do hands down for the best OBGY. Okay, and say this. Okay, OBGY ने बचा लिया, वरना महाभारत में विजय मुश्किल था. Same thing will happen with you, your videos coming like running commentary in my ear. Same thing will happen with you, my dear student, if you are stuck up. So many students get stuck up at the score of 130, 135. Then they take my OBGY, because minimum 15 to 20 marks more you are going to get in OBGY. लिख के ले लो. Minimum 15. All my students get 30 on 30 or 28, 29, 30. It's a single most important subject. If you have to clear FMG, you have to score very well in OBGY. Everything you will get, complete theoretical lectures, video based, all the recent advances, MCQ solving tricks, beautiful notes, my personalized timetable guidance, quizzes, everything. It will make OBGY your highest scoring subject. And still time is there, my dear student. Within few days, just study other subjects. You leave the entire OBGY preparation to me. You study other subjects, just give 1.5 hour daily. Within the next 15-20 days, you become champion of OBGY, is my guarantee. 5 months package only at 1200 rupees is what you are going to get it. Download the OGGuru app and use this freedom code and get in touch with me on phone and WhatsApp on this number. As I said, so many students are stuck up at the score of 130, 135 for 3-4 attempts. Then they take my lecture and the score jumps up to 160, 165. So minimum, if so many students are stuck up at 135, 140 also, you will do very well, because it's a single most important subject and you will do maximum. My guarantee, when you will walk out of the FMG exam, you will call me and tell me, okay, thank you very much sir, my best performance in OBGY. And FMGE फिर से मेरा goal एक. Please understand, it's very human nature. So many students, and please understand, the June exam was unnecessarily tough. The passing rate was very low. December exam will be easy because of lot of how halla has happened. December, the passing percentage is 100% going to increase. For December exam, the pass percentage will increase surely, and this is going to be the game changer for all of you OBGY. My dear student, paper will not be as tough as the June. Yes, video based images will come. Enroll in this and you will do very well in the exam. Get in touch with me and do not forget to follow us on Insta. Please hype this video. Subscribe to the YouTube channel for many more such interesting video. The PDF of this will also be uploaded on the Telegram, and message me if you have any doubts and difficulty, and I'm personally guiding all the students how to study, how to prepare. Thousands of students are directly in touch with me on phone and WhatsApp on the number provided. So enroll in the 5 months package. It's just 1200 rupees and OBGY will become your highest scoring subject and most favorite subject. And don't take fear of video based question. Video based question is very similar to IBQ, just an extension. Just see the video, read the question, you will be able to answer it. Many more videos based questions, such almost like 1.5 to 2 hour session of video based is already there on my app for all our students. Okay, bye bye, best of luck and thank you very much.